The rehabilitation of the knee. The knee is made up of 4 ligaments. If the knee ligaments have been damaged and does not cause pain upon compression but causes pain with traction, then we do not want to use traction exercises to rehabilitate the knee. We want to use what's called closed chain rehabilitative exercises. If I have tore the ligaments in my left knee, then I want to place the tubing around my right leg. The left knee is the damaged ligaments. The ligaments are stabilized by extension of the knee. I'm going to be doing what is called closed chain stepping up a hill. With the foot back, knee is bent, I step up a hill, pulling the right leg to the left leg. The left leg is actually doing the work. The muscle that is closest to the door is actually the muscle that I'm working. So right now, I'm working on the posterior glute stabilization, hamstring, gastroc, soleus, etc. down the back of the leg. I'm also stabilizing the anterior and posterior cruciate ligaments in this exercise. So this is stepping up a hill forwards. I step up, pulling the right leg to the left leg. The left leg is flexing, my toes inside my shoe are grabbing the floor, and I'm pulling the right leg to the left leg as I straighten the knee. If it's uncomfortable to lock my knee, then I don't lock it. I can make it as easy, short little steps, short little step up, or I can go big steps up. Big knee bend depending upon how strong I'm becoming. If I want to stabilize the medial collateral ligament, I stand facing sideways. I bend the knee, I step up the hill sideways. Left leg is pulling the right leg to it. All the muscle strength is coming from the left leg as I lift, squeeze, squeeze. The front quad, the anterior cruciate ligament, is being worked primarily in this exercise with some posterior cruciate stabilization. The knee is bent, stepping up a hill backwards. This is performed primarily in 2 touches. Touch here, touch here. The other ones are all performed in just 1 touch at the very back. So, touch, touch, step up, up. The quad is working extensively here. You can isolate out a VMO or vastus medialis by angling the quad a little bit at an angle, as in lateral patellofemoral syndrome. Step up, step up, step up. And the last one is called Eric Heidens, which stabilize the lateral collateral ligaments of the knee. So this is the knee. This is the affected knee. It always stays on the ground for stabilization, never leaves. You bend the knee and you push up a hill, up a hill, up a hill. Again, a 2-touch. Touch, 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 touch. Push up a hill, up a hill, up. Adjust the tension by how far and how big of a knee bend you need to perform. The toes are grabbing the floor, pushing the left leg away with the right knee, pushing it, pushing it, pushing it. Closed chain exercises for the knee. If it is the cartilage that has been damaged inside the knee and there is pain upon compression when a patient is standing on the knee and the ligaments are stabilized, then we want to use decompression or traction exercises to stabilize and strengthen the knee. Again, one of the best things you can do is place the tubing. Whoop, let's put the tubing a little higher. Place the tubing about 18 inches up. Place your foot or shoe through the tube. Have a seat in a chair. Adjust the tension that you want for traction. And first, you're working circumduction with traction. After this feels good, work inside, 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 inside. Then put the tube into the outside of the foot, pushing outside, 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 outside. Place the tubing again with an occasional kick to release the scar tissue and distract the knee cartilage itself. Then you can also do stabilization and pure traction by interlocking your fingers, lightly lifting the knee, and do some flexion. Then you place your foot, toe well on the ground. Stabilize the knee, spin. Put the knees together. First, you're going to kick the floor with your toe. Very easy, pure traction. If this feels good, lift the toe and attempt to kick the floor with your heel. This applies a tremendous amount of pressure to the quadriceps, stabilization, strengthening of the knee. In getting a full range of motion back in a knee, often knee stretches are indicated. I like lying stretches for the knee. Use of a towel. A long towel is good to give the patient lots of latitude. If you're going to do the knee, you put the towel around the patient's foot, and then the patient slowly extends the knee, applying a traction in this maneuver. Now, the patient then bends the knee, and works on flexion of the knee in this manner. A really good stretch for like lateral patellofemoral syndrome, where you have contractures of the lateral TFL, is to put the towel around the knee. The patient straightens the knee and then pulls it on the inside of the towel across, bending across, stretching the lateral TFL, bringing the knee across. And of course, the adductor or medial collateral ligament being pulled on the lateral side, stretching the inside of the knee. In conclusion of the rehabilitation of the knee, a short discussion about the use of a stationary bike is indicated. Oftentimes, patients will get on a bike and attempt to try to free a knee up by going in circles on the bike. It creates too much pressure. A patient's affected knee should be on the bottom of the pedal, and a patient's good knee should be flexed up. And then have the patient slightly raised backwards and forward, backwards and forward, backwards and forward, backwards and forward, until the patient can comfortably go around in circles backwards and freely spin forward. And that is just a conclusion of the rehabilitation of the knee.